Look, thank you. Oh, got it. Sorry. Thank you very much. I decided I'd present this case partly because I actually forgot which registrar I'd asked to give the talk, and I couldn't sort of pick on somebody with only 2 days' notice. But this patient I saw last week in the clinic, and they're quite interesting. Oh, how do I do? So I first saw this person in 2007, a 48-year-old man. He was referred with glaucoma, or presumed glaucoma, with a high pressure of 30 on the left side. And he had features of pigment dispersion syndrome with iris transillumination defects on the left, but not the right. He did not have a Krukenberg spindle, which is interesting. His trabecular meshwork was very heavily pigmented on the left, but not the right. And he also had what we call a Q sign on gonioscopy. He had the concave iris insertion into the angle. So it sort of went like this. And I found a photograph, but it's very hard to photograph because you really have to see it in 3 dimensions to understand what it looks like. So that Q sign is a sign of reverse pupil block. And so I booked him and did a YAG laser peripheral aeridectomy, I think a week or so later. I started him on latanoprost, and interestingly, the following year, the right intraocular pressure started to rise as well, even though he did not have definite signs of pigment dispersion in that right eye. So I only did the YAG laser iridotomy on the left eye. And here's just a photograph of not this particular patient, but a patient with the laser iridotomy. So over the following few years, so it's 15 years, you can see the intraocular pressure graph over time following starting latanoprost. You'll see it did spike up to 29 and then it settled, but it tended to trend downwards. And interestingly, the left eye became better controlled than the right eye. And I still don't quite know the reason for that, even though the left eye had the signs of pigment dispersion syndrome. But you'll notice that after about 2010, the pressure really did start to settle reasonably well. And these are the visual fields. So over pretty much most of those years, and they look pretty normal. Maybe have a look at the right eye. So the left eye is the one with the pigment dispersion syndrome. But have a look at the right eye. Perhaps there's some clusters of sensitivity loss, but it's relatively mild. It's hard to be extra convinced about that on the right-hand side. This is just recently, I think this is last week, OCT scan of the right optic disc, and the nerve fiber layer actually looks quite normal, as does the left. It's within the sort of normal limits there. This is the Heidelberg. Now, we've only got OCT scans going back a couple of years, but the Heidelberg goes back to 2008. So the confocal scanning laser ophthalmoscopy goes back to 2008. This is the left side. So this is the eye that had the pigment dispersion, had the YAG laser. And what we're looking for are large areas of red, and there aren't any significantly large areas of red within the neuroretinal rim area. And also, however, when we look at the right, you will see that, especially inferiorly and a little bit superiorly at the edge of the cup on the rim, I'm not sure if you can see my mouse. So in these zones, you'll notice that the machine is doing a subtraction analysis. It's subtracting the height values of the tissue from 2010, on this occasion, to 2023. And it's finding some significant loss of height in those two locations. What we can do is flicker back and forth. So I'll do this a few times. Perhaps look at the right eye. So look in this zone here. Oh, sorry. And you'll notice a change where you'll notice that the cup has increased in size, both inferiorly in this inferior zone here and this superior zone here. It's hard to get exact alignment, but I think you can appreciate how the cup has increased there somewhat. Whereas if you look over on the left-hand side, so the other side, there's really no difference in the cup or the neuroretinal rim. So again, it's a little bit unusual because we've just seen what looks like fairly convincing signs of optic disc progression in that left eye. In the right eye, I meant to say. And the right eye is in red, the right intraocular pressure. And you'll notice that, particularly in the last few years, the right pressure has been generally fairly reasonable, actually. And the left pressure has been about the same, maybe marginally below. Now, what has come out in the last couple of years is the ability to measure intraocular pressure at home using an eye care made for home use by the patient. So this is a picture of somebody using a home eye care. And we've got one and we loan it out to patients for 3-week periods. And the data from the home eye care is sent up to the cloud, and then we can access that data at the institute and draw down, and the software will plot graphs of the pressures. So we ask the patients to check the pressures 2 to 3 times a day, or more often if they can. And this is a graph of that patient's pressure over a 3-week period. The right eye, so the eye in question which had the progression, signs of progression, is in blue, and it looks like the pressure there is a little bit higher than the left eye, which is in red. And you'll see the highest pressure is 22, lowest of 10. The mean is about 16 versus the mean of about 12 in the left eye, which is the eye that had the pigment dispersion syndrome but has been stable with no progression. So what becomes interesting is when you look at the diurnal variation. So if you group those pressure values into time intervals during the day. So on the top graph is the right eye pressures, and you'll notice that the axis, the y-axis, is different between the left and the right eye, so just be careful of that. The right eye peak pressure is at about 18 in the afternoon, so from 3 o'clock to 6 o'clock in the afternoon, and then it starts to drop off. And that's, you can see the tightness of the standard error bars suggests that's fairly consistent. So that diurnal variation is relatively consistent in this patient. On the left eye, the pressure is obviously very low when the patient first wakes up, between 9 and 12. It's between 11 and 12, the pressure reading. Then it only goes up to about 13 typically. Whereas on the right-hand side, he's waking up with a pressure of about 15, and then it goes up to about 18 later in the afternoon. Now, the interesting thing is that I tend to only see him in the mornings. So, that started to occur some years ago. So that might explain part of why the pressure seems to have dropped in the last few years. The fact that I'm seeing him in the mornings, and I wasn't really aware of the diurnal curve variation. So he's progressing, and the right eye pressure is significantly higher than the left, and it seems to be peaking in the mid to late afternoons. So what are we going to, hang on, where am I? What are we going to do about this? Well, there's a couple of options. We could use more medications. He's only on latanoprost to both eyes, and we could add a beta blocker, or we could do SLT laser. We could operate, but his vision is excellent at 6/5, and he's got virtually normal visual field. But if you look carefully at that right visual field, and you'll see some clusters of reduced sensitivity in a slight inferior nasal step distribution. Without knowing that the disc had changed, you might say that's just some sort of random fluctuation, but knowing that the disc has changed suggests that those visual field defects or changes are probably real. So he's probably got some very, very early field change, which is almost not detectable. But in any event, I don't think I would like to do surgery on somebody with such minimal signs of actual glaucoma. And so that's why I've restricted the choices to medications or laser. Now, I had a chat. One of the beauties of timolol is that it does work very well during the daytime. And here's some fluorophotometry. So the effect of timolol on aqueous flow production is maximal during the day, but minimal at nighttime. And in this particular patient with the diurnal curve variation, it looks like we want maximal activity during the daytime. So I've said to him, let's try timolol, and we will try the home eye care monitoring in maybe a month or two's time again and see if it's made a difference. So in summary, this patient is unusual for several reasons. One is I would have expected the left eye with the pigment dispersion syndrome to have been the one that would have progressed. But interestingly, pigment dispersion syndrome is the only cause of glaucoma that I know of where the underlying disease can actually go away, as if you treat the reverse pupil block and eliminate further pigment dispersion, then the pressure can normalize. So perhaps that's what's happened here. But it was surprising to me that the right eye had progressed. And it's interesting that the diurnal curve measurements with the home eye care appear to have been useful for identifying the reason for the progression and perhaps helping guide the treatment, although of course I haven't done a follow-up home eye care set of measurements, so I'm not 100% certain. So that's my case, and thank you very much for listening to it. I'll stop sharing now. Thanks very much, Arti.
Thank you, Prof. Morgan, for the case presentation. Perhaps I would like to proceed with my presentation about trabeculectomy.
Yeah.
Okay, I'll share my screen. Is my screen visible, Prof?
Yes, it's very good. Thank you.
Oh, sorry. Wait, yeah, Prof. Sorry. Okay, let me start again. Yeah, so I would like to share about trabeculectomy, how to optimize the result and minimize the complication. So as we know that trabeculectomy is a guarded filtration procedure, and it is still a gold standard procedure for long-lasting IOP reduction in uncontrolled glaucoma. So to do the trabeculectomy, what glaucoma surgeons want? So the aim is to have IOP in low mid-teens without any medications and from day 1 to many years. And what about the things that we don't want? Of course, the complications. Here are some complications that we really don't want to do, like a suprachoroidal hemorrhage, wipeout, bleb leakage, blebitis, endophthalmitis, and also felt bleb. So the first three, usually it is also related due to hypotony, which influenced by the extent, suddenness of hypertony, and also the duration of hypertony. So we must know what kind of patients have risk for suprachoroidal hemorrhage. Here are the lists in the systemic condition and also ocular condition. So if the patient have some systemic condition like hypertension or using the anticoagulants or diabetes mellitus, so we must know that this condition have to be in a good control to have a low risk for the suprachoroidal hemorrhage. And for the ocular conditions, like the elevated pre-op IOP, high myopia, or previous ocular trauma or intraocular surgery, so this kind of patients also have a high risk for suprachoroidal hemorrhage. So we must be very cautiously to do the surgery. So what can we do? So before the surgery, we can modify some pre-op medications. Some of drugs that can cause conjunctival inflammations, like myotics and prostaglandin, we can stop it for 2 weeks, and probably we can switch to the acetazolamide oral. And we can also give some pre-op steroids just to maintain the conjunctiva to be more quiet. And also if the patient used some anticoagulants, from the study, it is stated that about 30 to 80% of glaucoma surgeons usually discontinue the anticoagulant for about 4 to 7 days before the surgery. And we'll resume the anticoagulants 1 day after the surgery. But sometimes we need to also consult to our colleague in internal medicine whether it is safe to stop and whether the risk is also have advantage for the patient. Okay, and also for the patients who already have very advanced glaucoma, we know that they have high risk for complication of wipeout, and they are very sensitive to IOP fluctuation. So it's best to have the patients sustain pre-op IOP control, and sometimes we may need to give some pre-op mannitol IV about 1 hour before surgery to get the pre-op IOP in a good control, so we don't get any suddenness of IOP decrease, which can cause the suprachoroidal hemorrhage. And also we need to avoid positive vitreous pressure. So we can control some controllables, like we can ask the patients to have bathroom break prior to the surgery, especially if we give mannitol. And we can use the lightweight or titanium self-retaining speculum and just open it to moderate extent. Don't open it very wide because it can also cause positive vitreous pressure. And here are the risks for trabeculectomy failure. Like the type of glaucoma, secondary glaucoma, like neovascular, uveitic, and traumatic glaucoma, and also some pre-existing ocular conditions like blepharitis, ocular rosacea, or previous surgery, and also some race like African race and young patients, and some steps of the surgery, like if we do superior rectus suture, or we combine with cataract extraction, and if the patient has a subconjunctival bleeding intraoperatively, and the post-op, if the patient have high inflammation or high IOP in the first 2 weeks, they also have a risk for the failure. And before the surgery, we need to assess the pre-op conjunctival health. because some of the patients may have a chronic redness and increased conjunctiva vascularization. Some of patients because of the glaucoma medications that we give, because they contain some BAK, and also some patients with the Sturge-Weber syndrome or with the NVG activated conjunctiva. So also the patient with previous surgery with conjunctival scars. So in these patients, we may need to use the MMC judiciously, or sometimes we may also consider whether it is safe to do the trabeculectomy. And then we also need to select side of the traps. Most of the surgeon will choose superior side because it's the widest area for a bleb and it is covered by the lid, so it's quite safe. And the PI also covered by the lid to avoid diplopia. We usually leave the temporal side for repeat surgery, probably for trap or tube in the future. And also in the study, it is stated that inferior trap with inferior bleb have a high incidence of endophthalmitis, 6 times risk than the superior side. And remember, the first trap is the best tech, so we must do our best. And for the step of peritomy, we can do like limbus base or fornix base. If you do fornix base, do it at limbus and use non-tooth forceps to avoid any conjunctiva tear or buttonhole. So here's the video. I usually give some anesthetic subconjunctiva, and then I use the entry point of the needle to venous to cut the conjunctiva. As we can see here, I cut it right at the limbus. Yeah. And then the next step, the peritomy, we must avoid inadvertently enlarge the peritomy. So when you go in, when you want to dissect the conjunctiva, you have to go in with the closed scissors. And then after you already inside the pocket, you can open it. And when you go out, also try to close the scissors. Okay, here's the video. Because sometimes if the patient also have a quite thin conjunctiva, it's really fragile. We can accidentally enlarge the peritomy. Okay, so between the limbus base versus fornix base, these are some advantages and disadvantages. But however, the IOP control is comparable. So for the limbus base, the advantage is it has a more secure wound closure. And the fornix base, the advantage have intraoperative benefits because it's quite easy. And the scleral exposure also quite good. And from the study also said that it has a better bleb morphology. The disadvantage of limbus base, it has a lead complication of leaks and infection. And the fornix base, the disadvantage is increased incidence of early bleb leaks. So it's actually surgeon's preference. And to do hemostasis, we just do light cautery. Cauterize only the vessels, not the sclera, because excessive cautery can cause the shrinkage and contraction of the flap. And tissue should remain white. The hemostasis is aimed to prevent vascularity and fibrosis by preventing the amount of bleeding. So like we see in the video, we just cauterize the vessels. Don't cauterize all the area, just light cautery. Okay. And then we move to the antifibrotic agents. Usually MMC and 5-FU are the antifibrotics that most common to use. The MMC has advantages because it has more potent than VIVE-FU, and it results in lower IOP. However, MMC also has disadvantages because it's more expensive and we must reconstitute from powder, and it is not stable at room temperature and possibly can cause some more complications than VIVE-FU. VIVE-FU has advantages because it's inexpensive and no need to dilute, and it is stable at room temperature and better safety margin than MMC. However, there are disadvantages because it's less effective than MMC, and probably we may need multiple injections and high incidence of corneal toxicity. So to applicate the MMC, usually it's quite varied widely. We can use it inject or sponge, like in this case, in this video. So this one is by inject at the tenon. And this one is like the most common use by using the sponge. So by injecting, it's usually quite fast rather than the sponge because we must wait in certain duration. So the sponge usually contain the concentration about 0.1 until 0.4 milligram per milliliter, and the duration is about 1 to 5 minutes. It depends on the case. We may need to apply it longer or with the higher concentration if the patient has high risk for failure. And if we want to inject the MMC, then we must use in more dilute concentration, like 0.05 until 0.2 milligram per milliliter. We must avoid the MMC to contact the wound edges, and don't forget to have the irrigation after apply the MMC. Okay, so the next step is to make a scleral flap. We must avoid all surgical sites or areas of scleral thinning. And usually we do a scleral flap in 1/3 to 2/3 scleral thickness, because if it's too thick, it could hamper the aqueous flow, or if it's too thin, then it become very fragile. And the shape can be rectangular, square, trapezoidal, or triangular. It depends on the surgeon, really. I don't think it's matter. And the size also vary, but ideally should be around 2 to 3 millimeter radially and 3 to 4 wide. So here's the one that I made with make a tunnel. Sometimes we can do like tunnel, or some surgeon also can just cut it side and to side. So it really depends on the surgeon. It's better to have a scleral flap smooth because it also can influence the fibrotic reaction. If you have a scleral flap not too smooth, then can cause more fibrotic reaction. Okay. Yeah. So when you reach near the cornea, like in this video, try to direct the blade, whether it's crescent or 69 blade, like in this video, a little bit up. So you need to follow the curvature of the cornea, then because then you can avoid any premature entry. Okay. Next, I usually do pre-placed suture. I think it's more safe to have a pre-placed suture because with the pre-placed suture, we can shorten the duration of hypertony after you do the sclerostomy. We can have a releasable or fixed sutures. It depends on the surgeon. So I usually make a lamellar corneal pocket to bury the releasable loop, because sometimes I found patients without this pocket, the loop of the releasable accumulates some mucus, and it can have a high risk to have infection. So I like to secure the releasable suture in a loop, in releasable loop in a corneal like this. So just make a very shallow corneal step. Yeah. Okay, and then you make a releasable suture. You can make one or two, one releasable and one fixed. It's flexible. It's up to the surgeon, and we must also assess later the flow of the aqueous. Okay, so and the next step also parasynthesis. Usually we direct the parasynthesis not to the center of the lens, because we may cause we may poke the lens. So here the directions is safer. And after that we do sclerostomy. We can do it by punch, Kelly punch, or we can do also manually using Vannas scissors. And then peripheral aeridectomy. So the peripheral aeridectomy also debatable. Some surgeons prefer not to do it if the AC is very deep, because they say that peripheral aeridectomy can also cause some inflammation. However, I think it's better to do the peripheral aeridectomy, because after the surgery, we may need to manipulate, like release the suture or sometimes massage. So it can cause hypotony and also AC shallowing. So sometimes because of this condition, then the iris can block the sclerostomy. So it's better to do the peripheral aeridectomy. And then the next step is closing the flap. So after the iridectomy, I usually flush a bit just to push away the iris to make sure that the iris will not block our sclerostomy. And then just tight the pre-plate suture, whether it's fixed or releasable. And then after that, we put some BSS to the intracameral to then assess the flow of the aqueous. And if it's if the flow is too high, then you may need to even add some more suture. So you must flexible. Or if it's too tight, no flow, then you can loosen a bit the suture. Okay, then the next step is conjunctiva closure. So some people use nylon, some people also use Vicryl. It depends on the surgery, depends on the surgeon. Back time, I usually use Vicryl. However, now I learned to use nylon, because when I see the patients, I think with the nylon conjunctiva closure, they have more quiet bleb, rather if I use the Vicryl. And also Vicryl, as we know, that can lose within times. So sometimes because it loose, then it can open the conjunctiva and can cause leakage. But it's also still surgeon preference. I'm sorry. So here are the steps to achieve an ideal blebs. So preoperatively, we can modify the medications and assess the conjunctival health and plan the site of trap and amount the MMC. And intraoperatively, we may need to do gentle conjunctiva handling and careful scleral flap and conjunctival suturing, and minimum intraop complications. Postoperatively, we need to manage the medical management, and also we need to manage the bleb. And remember, planning is as important as execution. So post-operative management, we may need to give vigorous topical corticosteroids 4 times daily up to every 2 hours, and then we can taper over 3 months and give brief topical antibiotics and discontinue oral carbonic anhydrase inhibitor and other glaucoma meds. And sometimes we need to give cycloplagia, especially if we suspect some patients that may have some shallow anterior chamber after the surgery, or if the patient have an angle closure, then you can give cycloplagia. And we must instruct the patient to avoid carving, falsava, vigorous physical activity, or lifting during post-operative period. And we need to modulate the IOP by releasing the scleral flap sutures, either by laser suture lysis or by removal of releasable sutures. Because remember, after we doing the trabeculectomy, it doesn't mean that the management is stopped, because the patient still have bleb, which is very important to manage if you want the trabeculectomy have a long-lasting function. So how to modulate the post-op IOP? We can do by digital pressure, or we can do laser suture lysis or remove releasable suture. However, we must know that we do not too soon. Probably better if you can hold until 2 or 3 weeks, it's safer. And watch out for the last suture, because it can cause hypotony. I think that's all from me. Thank you.
Thank you very much, Ardiella. That was a really great comprehensive talk on trabeculectomy. Now, I'm just going to see, I'm not very good with the Zoom, sorry.
Okay, Prof. I think there's some one question from Mita. Do you want me to read, Prof?
Yeah. Oh, here we go. I found it, sorry. Mita, yes, thank you very much, Prof. Morgan, for the interesting case that you present. Oh, sorry. Sorry about that. It is nice to have access to patients' diurnal IOP through the home eye care. In cases where we do not have that facility, what is your suggestion to predict the IOP fluctuation of our patient? Do you think the water drinking test is useful? Yes, that's a great question, Mita. Yes, I do think the water drinking test is useful, and it's probably the next best thing. We used to do a diurnal curve. We'd bring patients into the hospital for a night years ago and have nursing staff check the pressure with a tono pen. But the problem was it was hard to teach the staff to do the pressure accurately, and some of the patients ended up with corneal abrasions. So we stopped doing that after a while. And I think the water drinking test probably is the next best thing. Even that, there is a strong correlation between fluctuation on water drinking test and that seen with a true diurnal set of measurements, but it's not 100%, so you can miss it. Yeah, I suspect though in the next 5 to 10 years, home pressure measurement systems will get cheaper and more common actually. Now, have we got other? Oh, here we go. We've got other questions too. Dear participant, thank you very much. Oh, have we? I had a question for you, Ardiella, on the trabeculectomy. Oh, sorry, Werner's got a question. Werner.
Yeah, it's the reason.
About your case, Professor Morgan, I think it's very interesting because you know that it seems like you got a patient that have a progression, although it is it is not very prominent, but it's like obviously that this patient has a progression, but but still you know that it is like still in the pre-perimetric glaucoma, right? Because actually the progression without harm-free or perimetry decrease, visual field disturbance. So we could see that only the HRT examination catch up with the progression, right, Prof?
Yes, that's right.
In,
Yeah, that's right. So you could see some small visual field sensitivity losses around that nasal horizontal line, which may or may not be significant. It's probably too early to tell. So I agree. I think at the moment you'd say it was virtually pre-perimetric glaucoma. It's probably almost as early as one can detect glaucoma. And it's worth noting that the OCT nerve fiber layer scan metrics were well and truly within the normal limit. So what's that? That's basically telling us that in some senses that's not relevant. What is relevant is whether it's changing or not. Yeah.
So Prof, if we sometimes we face patient with condition, maybe even we have a progression, or maybe because it is like, you know, slowly progressive, in the nature of glaucoma patient, right? So in case like this, if we do like SLT, because it is like pigmentary glaucoma, and in the theory that usually the SLT work more in the pigmented area. So what do you think in a patient like this? Is it safe to do the like SLT in this patient? Or even I know that in some case in the textbook they mention about the peripheral aeridectomy to reduce the, you know, there is in pigmentary glaucoma, we know that there is a discrepancy of IOP between the posterior chamber and the anterior chamber. So in the gonioscopy, sometimes we found like a concave appearance, right, Prof? For pigmentary glaucoma. So is it worthwhile if we do like a laser iridotomy peripherally in this patient to make the IOP between the posterior chamber and the anterior chamber quite the same? Or you will choose like SLT or things like that to maintain the IOP? So we hope that the IOP will like more stable during the time. What do you think, Prof?
Yeah, so I think this patient, the left eye, the one that did not progress, had the pigment dispersion syndrome. It had the concave iris, so the Q configuration. So in my own practice is, if there is that Q configuration in the pigment dispersion, I will do, or I'll recommend YAG laser iridotomy, and it always normalizes that configuration. And the studies have shown that it reduces pigment release and dispersion. And over time, the intraocular pressure often settles. So it is the one cause of glaucoma that you can actually cure or treat permanently. I mean, most of what we do in glaucoma is really Band-Aid treatment. We're putting in drops or doing surgery. We're not addressing the underlying problem with the trabecular meshwork. But here with pigment dispersion syndrome, we actually are, by reducing the pigment release, which is blocking the trabecular meshwork, you can actually normalize the intraocular pressure and make the meshwork more healthy. So that's, I think the first decision point is, if there is reverse pupil block, recommend a YAG laser iridotomy. If there is no reverse pupil block, so if the iris insertion's flat, then I think it's more difficult. I don't think there's evidence to suggest that it actually, laser iridotomy actually works. It's harder to know. Yeah, and then in terms of if the pressure had remained elevated in that eye, then I might have considered selective laser trabeculoplasty. It does work quite well, most patients with pigment dispersion. So with the other eye, the right eye was the one that actually progressed, but that had no signs of pigment dispersion. The meshwork was not pigmented. And And so I didn't think, I mean, one could use selective laser trabeculoplasty, but its success rate would be the same as the average population. I don't think it would necessarily be higher than, as high as for pigment dispersion syndrome. And I don't know, usually it's bilateral, but here it was unilateral.
Yeah.
It's quite unusual.
It's very unusual. Oh, I see. Okay. So because it is a bit different condition between the other eye, right? So that's so okay. I could understand that why you only choose the medication in this case. Because
yeah. That's right.
okay,
And I didn't do laser on the right eye because there was no pigment dispersion.
Yeah.
The iris insertion was straight. There's no reason to do a laser iridotomy. But I don't know why the pressure went up. So
that is interesting, Prof, because like we usually found pigment dispersion syndrome in both eyes, right? So it's in the oh, okay.
Yeah.
Okay. Yes, Prof. We will see the next few years maybe for this patient whether it will develop glaucoma or not, right?
Yeah.
Thank you, Prof. Yeah. Thank you so much for the interesting cases, Prof. Thank you.
Oh, that's a pleasure. We've now, Now I had a question for Ardiella, and I'm just trying to remember what that question was. It's to do with your trabeculectomy technique. Oh, I know what it was. The mitomycin C. Do people inject mitomycin C sometimes? And I saw that, I think the dose you quoted was something like 0.1 to 0.3 milligrams per mil. I'm wondering what volume, and I'll tell you the reason I ask this is with the Zen stents, I used to inject 0.1 milligrams per mil. I think it was about 0.1 of a mil. The total dose was about 37 micrograms of mitomycin. And I had a number of patients who got very ischemic blebs, which made me worry that I was giving them too much. So with the Zen stents, I only inject about 5 to 10 micrograms, which is actually between, it's 50 microliters or 100 microliters. So 0.05 to 0.1 mil of the 0.1 milligrams per mil concentration. But the thing about a trabeculectomy is that you're causing much more sort of trauma to the tissue and provoking more scarring. But yeah, so sorry, do you personally inject mitomycin or do you apply it by sponge? And if you do inject, how much mitomycin are you injecting under the conjunctiva?
Yeah, Prof. So now I'm trying to do the inject, I think, because some of my patients shows better bleb morphology if I inject rather than using the sponge, because if I see if the patient with the sponge, it's more localized. If I inject, it's more diffuse. And it's less vascularized, Prof. The concentration I use 0.2 milligram per milliliter. So it's a half than I used to if I use sponge. And I usually inject about 0.2 milliliters, Prof. Yeah. But I think it also depend on the race, Prof, because Indonesian people have quite a high inflammation reaction if probably compared to Caucasian. So yeah, probably we have to apply different concentration if it's Caucasian, because I know that Caucasians have quite a lower risk for inflammation, yeah, Prof.
Yeah, that's true. In general terms, that's correct. So 0.2 milligrams per mil at 0.2 mils of that is about 40 micrograms. Yeah, that's similar to what I was using with the Zen stents, but I think the Zen initially, so now I use 1/8 to 1/4 of that with the Zen stents, but the Zen stent, you're not causing much tissue trauma. So that probably is about right. Yeah, that's interesting. And do you stop prostaglandin agonists or other agents for 2 weeks before you do the trabeculectomy? Is that your routine, or?
Well, it's actually quite difficult to stop, Prof, because
Yes,
usually
yes.
here in our institution, we have a very high IOP, so it's difficult to stop. Sometimes also we give already the acetazolamide oral, so the eye pressure is very high. So I usually do not stop the prostaglandin, Prof.
Yeah, no, I'm the same. I have the same problems and it's also then I'm not sure if the patients are going to follow the instructions correctly, and they'll come to theatre with a pressure of 40 and increase the risks of choroidal hemorrhage or something like that. It's a difficult one. I know some of the Europeans, when they speak, they say that they stop the drop several weeks before and treat with topical steroids, but I've never actually met a surgeon who actually does that in practice. So I think it's the sort of thing that gets talked about. Maybe we should do it in some patients. Perhaps the only time I've done it is patients who've got a severe allergy, such as bromonidine or some other drug, and I put them on a topical steroid. But yeah, I'm with you on that. I think it's in practice, it's very difficult to do, actually.
Yeah, Prof. Prof, I think we have one question here in the chat box from Anissa Wicaksono. Do you want me to read, Prof?
Yeah, yes, that would be good. Thank you.
Thank you, Prof. Morgan and Dr. Ardiella, for the presentation. I'd like to ask when to choose fixed suture over releasable suture. Is it mainly surgeon's preference? And if the BLEP and IOP is stable, does the releasable suture still need to be released after a certain period of time? Okay.
Ardiella, this is for you.
Yeah. Okay, Prof. Probably I will try to answer it first. So when to choose fixed suture over releasable suture? I think it's more of a surgeon preference. However, sometimes I also prefer to do just fixed suture rather than releasable suture. If I know that I cannot, in the future, I cannot release the releasable suture, such as probably in non-cooperative patients or like in kids. So I prefer to use just fixed suture, or if the patient have a higher risk of hypotony, so probably it's better just to do fixed suture. Even though if we use fixed suture, we can also do laser suturization. So I think it's no problem. It's just if you do the releasable suture, probably it's you can save time not to do laser suturization. You can just pull it in your clinic. However, doing the laser suturization is also not a difficult one. So I think it's more like surgeon preference. And the next one, okay, if the BLEP and IOP is stable, okay, sometimes we don't need to pull the releasable suture. If the IOP is stable, sometimes you just leave it there. If you know for sure that it is safe to leave it, because sometimes the loop it's a little bit like accumulating some mucus, so better just to pull it if it contains some mucus. But if it's quite safe, and then if it's quite buried under buried inside the cornea, I think it's already actually also safe just to leave it. But if you can, just release the releasable suture, because sometimes some sutures also can cause a little bit inflammation with the patients. So just adjust the condition of the patients case by case. I think if you see that it's more vascularized and more inflammation, then it's better to just pull the releasable suture. I think that's my answer, Prof. Probably you want to add some more?
No, sounds good. I mean, I think as you said, every surgeon is different and you have your own preferences. I use Tenno Vicryl, and I use one releasable suture on every case that I do. Partly, I used to use nylon and do suture lysis, but occasionally you get hemorrhaging over the nylon, as in just in the tissue, and then you can't use laser suture lysis. So one advantage of releasable sutures is that you can always release the suture, whereas sometimes you can't laser the suture. And it's also difficult to laser Vicryl. It's easier to laser nylon. Because I use Vicryl, I use a releasable suture. But what I find is that if you've used 5-fluorouracil or no antimitotic, you really have to pull the releasable within the first few days. Otherwise, it makes no difference because this fibrosis is starting to occur. With mitomycin C, I think you have about 1 week or 2 weeks. After that, it's unlikely it'll make that much difference, although sometimes it can. With Vicryl, I don't always pull. In fact, I hardly ever pull the stitch. It's more for insurance, but that dissolves, so I don't have to worry about it, basically. With nylon, I would tend to remove the stitch at some point. Just I'm worried about the nylon poking up and causing a problem. That's my own take. Thanks, Ardiella.
Thank you, Prof. We also have one more question, Prof. Let me read the question. To Prof. Morgan, thank you for the nice presentation. I'd like to ask how we could measure the diurnal fluctuations of the IOP in patients in daily practice. Thank you.
Yeah, look, it's not easy. I think that, so I mentioned that we used to admit the odd patient to Royal Perth Hospital, have the nurses check the pressure, or the resident doctor check the pressure during the daytime and the nurses at night, but that became difficult. We don't have the resources now to admit patients for that sort of not urgent reason. And also, it was difficult to teach the nurse or people how to check pressures. We do sometimes bring patients in across the day in the clinic and have the resident check the pressure or the registrar. But again, that can be, if the registrar or the resident are busy, you're not sure how accurate the pressure measurement is. What we were doing was using water drinking tests, because at least that way it was a sort of predictable set of measurements and you could make sure that you had a good technician checking the pressures. But now with the home eye care, because the patient checks the pressure so often, even if they get the odd bad reading, if the technique's not perfect 100% of the time, because they're taking so many measurements, the errors will kind of iron themselves out just by averaging over time. So I think it's been quite helpful for us. I actually saw another patient yesterday or on Monday with a similar type of difference in the diurnal variation. So I think it's too early to tell how useful the home eye care is, but my hunch is that it's probably going to be fairly useful. And I think there'll be lots of, when the patent runs out, which might be another 5 or 10 years, I suspect there'll be lots of companies making them and the price will come right down. So that would be quite a happy time for us and our patients, I think.
Yeah.
We have,
Yeah, we
Oh,
have another question, Prof.
yes. Thank you, Prof. Morgan, Dr. Ardiella. I'd like to ask if we have a patient with a low platelet count around 100,000 platelets that needs a trabeculectomy, is it safe to perform the surgery? Is there any cutoff that we should keep in mind? Or do we still need to stabilize the systemic condition first? Ardiella, that's a very good question, actually. Since you talked about trabeculectomy, I think you should be the first to answer it, if you don't mind.
Yeah, Prof. So I don't know actually about the cutoff of the platelet count. However, I'd like to have a good condition before surgery of the patients, because I need to make sure that there is no risk for the suprachoroidal hemorrhage or bleeding or anything that can cause the trap failure. So if the patient have a low count of platelet, I think I will just wait. If the trabeculectomy is not an urgent thing, then I will probably consult to internal medicine and ask whether is it safe enough to do the surgery, or probably they can also correct it first. I think it's safer, Prof, because we know that trabeculectomy can cause bleeding, so it's better just to wait. What about you, Prof?
Yeah, I think exactly. I'd be asking for internal medicine or physician review of that patient, I think. I'm wondering why the platelet count was low, what the cause is, as well as how low. I think if it's 100,000, you might operate. If it's 50 or 20,000, I think I'd be pretty scared, actually. But then I would get an opinion. That question raises you presented in your talk. This was the other question I was going to ask you. It was about your anticoagulation regime. When you said that patients on anticoagulants, I think you said stop the anticoagulants 4 to 7 days or 4 to 5 days before surgery. Did you mean that for both warfarin as well as the other agents, the Eliquis, those newer agents that are not warfarin related? Eliquis, I can't remember the names of the other ones, sorry, my hematology is so old, I've forgotten what part of the coagulation cascade they work on, but those newer anticoagulants for atrial fibrillation, which we see quite a lot of, actually.
Yeah, Prof. So for the anticoagulant, I think it has many kind of anticoagulant, and also about the duration, how long that we have to stop, it also have a different between the institution. However, if the patient is using anticoagulant, I actually, if it's quite have a high risk for the coagulation, then I prefer just to consult first, Prof, whether it is safe to stop the anticoagulant to do the surgery, and for how long. If it's like INR, I think there's some cut off the INR, but I forgot the exact number. Sometimes we can do like bridging the therapy with the warfarin. However, I will just better consult to the internal medicine, which know best about the condition, Prof. So if the patient have using the anticoagulant, better if you're not so sure, just ask the internal medicine about it. So I don't have any cut-off, Prof. It's just that some study said that about 4 to 7 days. Some just stop it for 2 days, and some surgeons even don't stop it at all. So I think it's different between the surgeons, Prof. Yeah.
Yeah, my view is, I'm just having a quick look, actually. So apixaban is the proper name for Eliquis. That was the first of the factor 10A clotting inhibitors. And that the effect wears off within 24 hours. So, and there are several others in that same class. So I tell patients to stop that drug 2 days before surgery, just to give myself an extra day. And I usually check that with their cardiologist. So just in case they're very high risk and the cardiologist wants me to use heparin right up until surgery. But with warfarin and the INR, I want the INR to be below 2. So usually therapeutic range is between 2 and 3, but I want the INR to be below 2 before I'll operate on them. And usually they have to stop that 4 days or so before, and I'll want them to have their INR checked the day before or the day of surgery with the result in theatre, just to make certain that the INR is down. So the warfarin is more of a worry to me. The apixaban or those types of drugs, as long as the patient has stopped it 2 days beforehand, I don't think you will have a problem with those. And you can't measure the level anyway. But so I think there is a difference between the warfarin and the apixaban related drugs in terms of what the recommendation should be.
Yeah.
That was a very good question. Thank you. From Karinia. Well, thank you. Ardiella, you've presented a really great talk.
Thank you, Prof.
And provoked lots of questions. And am I missing anyone else who's asked a question? Because I'm not always very good with the chat function. I think we've answered all the questions.
I think we already run all the questions, Prof. Yeah.
Okay. Well, thank you. And I hope the weather is good in Jakarta and in Indonesia. It's a bit cold in Perth. We've had some people visiting from Bali, from Yunard, and they were cold, actually. I think the first thing they did was went and bought some more clothes. So I'm sure it's a lot warmer up in Indonesia. Thank you, everyone. Thanks very much.
Yeah. Prof, probably before we conclude this session, we may need to take our picture with all the...
I'll take my glasses off.
Yes, all the participants. Okay, so all the participants, please open the video if you want to take a picture together. And I will ask Dr. Miki, please help us to take the photo.
Okay, thank you, Dr. Ardiella. Good evening, everyone. I would like everyone to open up your camera for the photo session. And I will use a burst mode, so please hold your smile after the count of 3, okay? Okay, I will begin taking the picture. 1, 2, 3. Okay, all done, Doc.
Oh, thank you. That was quick.
Thank you, Miki. Thank you very much, Prof. Morgan.
Thank you, Ardiella. Thanks, everyone. It's been fun.
Thank you, Prof. Thank you, everyone.
Thank you, everyone.
Bye.
See you all in the next month.
Yes, yes.
I think Prof. Morgan will be coming.
Oh, really?
Oh, yes. I'll be there in person. I'm looking forward to that.
Oh, nice.
It's in
Thanks.
early August.
Yes.
See you, Prof.
See you.
Bye.
Bye. Bye.
Bye.
See you. Bye.